Good morning, everybody, and happy Doctor's Day to all. Today, I'm going to discuss about the surgical candidates for HCC. It's a vast topic, but I will try to remain focused and bring some candidacy. Background, I will go through surgery for HCC, selection criteria, more tumor-based and underlying liver function test. So, liver cancer, all of you know, is the sixth most common cause of cancer worldwide and third highest cause of cancer-related deaths. And probably I will like to say that solid organ cancer, which have probably the vast and variety of treatment available in modern practice. But subsequent to that, the management of HCC is not a cookie cutter that you can fit everyone into that, or one size fits to all, and a tailored approach is required in most of the cases. If we look at the epidemiology, the HCC is anticipated to rise again due to increasing rates of MSLD and alcoholic liver disease, though we have taken care of the viral hepatitis related hepatocellular carcinoma in the last few decades. And patients, again, treated by a multidisciplinary tumor board have increased access to curative treatments, and that have shown to be translated into improved overall survival too. So I will try to focus this talk on liver resection for hepatocellular carcinoma, as the subsequent talk is about liver transplantation. So, liver resection historically considered as a curative approach for HCC. 5-year survival rates are reported following liver resection up to 70% over last 2 decades. Though liver transplantation is theoretically considered as the best treatment of HCC because it's a radical treatment, removes the primary organ in total, then it takes care of the associated CLD and thought to be have the lowest rate of recurrence. But compared to liver transplant, liver resection can be applied much more widely, and though it is still considerably associated with postoperative morbidity and mortality. The early and late recurrences after resection remains a challenge, needs to be addressed. Then when we are considering any candidacy of a patient, whether he is candidate for liver resection, then 4 things I think come to the mind. This is for our basic understanding. So how is the patient, how old he is, whether he is comorbid, fit, what is the etiology, what is the performance status. Next come to how is the tumor burden, what we will call, is the size of the tumor, number of the nodules, whether there is vascular or biliary invasion present, any extrahepatic disease like lymph nodal disease, which makes it tricky, and metastatic disease. Then next come to liver function. Well, I'm going through very basics, whether it is cirrhosis versus no cirrhosis. If cirrhosis is, or whatever in both the cases, if we plan for a liver resection, what will be the future liver remnant? Then comes the concept of presence of portal hypertension. More importantly, clinically significant portal hypertension, and there are various scoring systems where we can anticipate the candidacy. And then the last but not more important is biological behavior, is the tumor markers, then if there is any response to downstaging, or if there is a mixed like hepatocholangio type variants of the primary liver tumor. So for me, and it's a very complex algorithm, to be very frank, but what I can show you that in this algorithm, this is updated BCLC 2022, surgeon has a very limited role. Liver resection has a very limited role. If we can consider this, I will go back from this resection, then the bilirubin has to normal, the portal pressure has to be normal, then it has to be a single lesion, and here. Though most of these BCLC or other guidelines address more of the cirrhotics, but I would like to clear you. For a non-cirrhotic patient, all attempts should be made if the tumor is resected for resection. Then coming to that evaluation is a patient tumor burden, liver function, biological behavior. I will address it subsequently. Age for a patient, etiology of liver disease, performance status, sarcopenia. And this is a recent review published in ANZ as a meta-analysis, whether we can offer a curative resection for a patient's extremes of age, because a lot of evidence is that patients above 65 or above 70, curative liver resection can be safely applied. So that's why I have taken this the next level of fear. And they have included 8 studies involving 253 patients above 80 years who underwent curative intent liver resection, either open or laparoscopically. And they had more advanced stage of SCC compared to the younger patient. They have higher overall morbidity, more post-operative ileus, more incidence of delirium, more cardiovascular events, but the overall survival and disease-free survival are similar compared to the younger population. So again, if in this subset of patient extreme age, we have to take a multidisciplinary decision whether we can offer surgery. If it is a minor liver resection, we should positively consider such patients for resection. Another important aspect which is currently coming up is sarcopenia in patients who are undergoing liver resection. So it's almost half of the patient. This is a recent retrospective study published in American Surgeons. Half of patients have sarcopenia, that is significantly correlated with the skeletal muscle index, have lower muscle, lower serum albumin, higher intraoperative loss, post-operative period, higher post-operative complication, longer hospital stay. 5-year overall survival is significantly lower in sarcopenics, and but the disease-free survival is not different. Multivariate analysis, sarcopenia was an independent predictor of worse outcomes. This is another meta-analysis published recently, and it has shown similar results that, and this added that it not only shorter overall survival, but it has worse disease-free survival. Coming to the etiologies, there is controversy about whether viral hepatitis HCC do worse or NFLD does worse, and there are in reports both in the favor and against metabolic liver disease. So this is another published in Annals Open meta-analysis, 15 retrospective studies, 7,000 patients with SCC who underwent liver resection. About 20% have NFLD, 6,000 have other causes. But what they have shown in this meta-analysis, NFLD had a better disease-free survival and overall survival. Overall survival versus if we compare in among the etiologies, NFLD does better in compared to viral hepatitis as well as alcoholic and cryptogenic cirrhosis. So this is the overall survival trend that they have shown, and this is free survival trend when they have compared with other etiologies, and then again independently whereas according to viral and alcoholic hepatitis. After this etiologies, what important is and most widely debated is tumor burden. Okay, which patients will get benefit out of resection? The tumor burden we can analyze by size, whether it's a single or multiple, then whether there is associated vascular invasion, biliary invasion, or lymph nodal disease, but no other metastasis. So this is another interesting study of published around 2018 in British Journal of Surgery, long-term survival of patients undergoing liver resection for very large hepatocellular carcinoma. So they have about 11,000 adult patients with HCC and a median follow-up of about 72 months, and they categorize the single HCCs into small, less than 3 centimeter, medium 3 to 5 centimeter, large 5 to 10, and huge more than 10. And on multivariate analysis, they shown that size affected the long-term survival. Then prognostic factors for huge HCC were surgical margins less than longer than 0.2 is better, poor differentiation has worse outcome, multiple tumors, vascular invasion, presence of cirrhosis, and use of nucleoside analogs was reported as. This is the Kaplan-Meier curve which shows the overall survival for liver resection for single HCC according to the tumor size, and as you move from small to medium, large, and huge HCC, the survival is decreased over a period of time, and it is statistically significant. But till there is, though I have taken one of the largest series, there is data that single large HCC probably have a different biology than multinodular disease, and attempt should be made to resect them whenever possible. This is probably, from my understanding, is one of the most controversial indication, number of nodules, what to do with the multinodular disease, if the patient is a candidate of surgery or no. So this is a hepatology paper, 2018. Most of you might have gone through it, but it's a high quality studies. There are almost 1 RCT, 7 non-randomized studies, and about 10 to 11 retrospective studies, and about 6,000 patients compared either partial hepatectomy or TACE. BCLC-B and C stage patients have been taken, and when the overall survival was compared, partial hepatectomy have better survival than TACE. 5-year survival rates of partial hepatectomy were significantly higher than those for TACE in BCLC stage B and stage C. So, and in this, I'm not going into the very details of this, but what they have shown that the survival benefits persisted along all the subgroups. So then, after this is another BJS paper published in around 2019, hepatocellular carcinoma tumor burden score to stratify prognosis after resection, and they have developed a score that basically adopted from a colorectal liver metastasis. What out of this complex, what I can understand, they have put the maximum tumor diameter on the x-axis, then the number of nodules on the y-axis, and by the Pythagoras theorem they have taken the C as the tumor burden score. So the tumor burden score square is equal to maximum tumor diameter square plus number of tumor square. We can correlate this is similar to metro ticket approach for liver transplantation for hepatocellular carcinoma, and they have studied about 1,053 patients of SCC undergoing hepatectomy. Of that, they have compared it with BCLC stage. According to BCLC, 6% 0, 78% A, and 50% B, and they have stratified the total tumor burden score as high, more than 13.74, medium 3.36 to 13.74, and low is less than 3.36. Then they compare the overall survival, which worsened incrementally with higher tumor burden score. 5-year overall survival was 77.9%, 61 and 39% in low, medium, and high TBS. No difference in overall survival were noted among patients with similar TBS, irrespective of their BCLC stage. Patients with BCLC, BHCC, and a medium TBS had better OS than patients with BCLC A disease and a high total tumor burden score. On multivariate analysis, tumor burden score remained associated with overall survival across patients with BCLC A and BCLC B. TBS stratified was also in these papers via external validation cohort. And then what they have showed that overall survival was 79, 51, and 28% for low, medium, and high TBS respectively. So this is the diagram which we can see. There are multiple lines in this. It is BCLC A for the 3 which has with associated low TBS, in medium TBS and high TBS. Then comes the BCLC B with medium and high TBS, and as we show go through these lines, the best survival is seen with BCLC A and low tumor burden score, and the worst survival we can see is in the BCLC B with high tumor burden score. So coming after tumor burden comes is the vascular invasion, and that is another predictor, because vascular invasion in SCC.
What tumor burden will you take? It's not clear. What size and number of tumors will you be able to operate? Because all this is just collecting the data. What tumor burden, what size, number is resectable?
Sir, usually it is...
based on all this latest data, I'm still not clear. So how do you calculate tumor burden score? Tell me again.
Sir, if we go that, if we have 3 lesions and the largest is like 4 centimeter, then it will be like square of 4 plus square of 3, it will be 25, then the TBS comes to be 5, and then for the TBS of 5 is in the medium category. If I
So
take
4 lesions, 4 centimeter.
3 lesions, 4 centimeter.
So
I'm
it's
simple mathematics, because square of 3 and 4, then the tumor burden score comes 5.
5. So what is the tumor burden score? Are we using this tumor burden
No.
score? No. Should we use it?
We can use it. Coming to the vascular invasion, just for the reference, this is the portal vein tumor thrombosis classification according to the Japanese A. VP1 is the tumor thrombus distal to second order branches of portal vein. VP2 is invasion of the second order branches or sectoral branches of portal vein. VP3 is the primary first order branches like right portal vein or left portal vein. And VP4 is involvement or the extension of the tumor thrombus in main portal vein or the contralateral branch of portal vein. So again, there is a JOH paper, survival benefit of liver resection for hepatocellular carcinoma associated with portal vein invasion. And in this is another very large cohort study, 6,000 patients with PVTT, and the study period was from 2000 to 2007. Liver resection was performed in almost 2,000 patients, and 4,300 received other treatments. The propensity score matched in about 1,000 patients, 66% of the liver resection group. CTPA, the medium the medium survival time in the LR group was almost about 1.77 years longer than the non-liver resection group. In the propensity score match cohort, MST was around 0.88 years longer than that in the non-liver resection group. Resection provides a survival benefit regardless of age, etiology of HCC, tumor marker elevation, and number of tumors in presence of portal vein tumor thrombus. The survival benefit was not statistically significant only in patients with PVTT invading the main trunk or contralateral.
What was the AFP? Alpha fetoprotein in
Sir, except if it is not like extensive main VP4, that even a reconstruction is not possible, then.
Because I'm not sure the message what you are trying to give, Shridhar. So you will operate a patient with PVTT of what grade? What stage of PVTT, type of PVTT did they operate?
Sir, if you ask me this.
No, in this study,
Sir,
did they operate is VP4?
They operated, but they have shown that it has worse survival, except VP4 thrombus.
VP4 70-80% would have probably failure of surgery. With VP4?
No, sir. They are not recommended. They have shown that they have worse survival. This is PVT liver resection versus no liver resection overall. That they have shown the survival difference, and then this is about after the matching, they found that till the survival difference is there in the resection group. So if we go to the multivariate analysis in what they have shown that liver cirrhosis, tumor size, number of nodules, AFP more than 15, and VP4 thrombus and R2 resection have worse survival rate, or the independent predictor. VP4 is very tricky. Unless if it is just we can milk out the tumor, and then vascular reconstruction can be performed safely, then can be attempted in very selected patients. Not all patients is a criteria. So again, in this subgroup, what they have shown that the extent of PVTT, VP1 to 3 has similar survival, VP4 have worse survival after surgery. So coming to the next, liver function, cirrhosis versus no cirrhosis, FLR, clinically significant portal hypertension. Then, as all of us know, cirrhotic patients have higher incidence of post-hepatectomy liver failure compared to the non-cirrhotics, and that's why the future liver remnant is at least 40 to 50% is expected. Sorry, I skipped that slide. And Then comes to the clinically significant portal hypertension. The definition of this varies in the literature, and usually the hepatic venous pressure gradient of 10 or above is considered CSPH, or direct portal venous pressure of more than 20 centimeter of water, or there are surrogate criteria which includes presence of gastroesophageal varices or thrombocytopenia of less than 100 and splenomegaly. And some studies have included ascites. Then the minor criteria, any two of the three, like thrombocytopenia, splenomegaly, or ascites, is considered CSPH. So a significantly higher postoperative mortality in portal hypertensive group. The portal hypertensive group also demonstrated higher occurrence of complications, liver-related morbidity, and liver failure compared to the control. This is the odds which goes that CSPH is not associated with worse outcomes after liver resection, both mortality and morbidity. Then again, this is another paper from hepatology, portal hypertension and outcomes of surgery for HCC in compensated cirrhotics. So the 11 studies were included. There was moderate heterogeneity. The presence of CSPH increased the risk of 3 and 5 year mortality versus absence of CSPH. 3 years pooled OR was 2.09, 5 year mortality was 2 times higher. CSPH increased the risk of postoperative clinical complications. CSPH evaluated by any method significantly increases the risk of 3 and 5 year mortality and of clinical decompensation after surgery for hepatocellular carcinoma. Then another meta-analysis published in HPV, which have similar EA, but what they have shown that the impact of CSPH is not that significant in especially European patients when the surrogate markers and not the direct pressure measurement is taken into consideration. So as I mentioned, FLR, what we in cirrhotics, about 40% of FLR is to be expected to reduce the risk of PHLF. PHLF and SCC recurrence multivariate analysis revealed that why we are worried surgeons of PHLF, that significantly associated with poor overall survival and recurrence-free survival. Extent of resection, operative blood loss, fibrosis are independent factors of developing PHLF. Then this is in a cohort, this is study in 2014, how PHLF have shown affecting overall survival in HCC patient after resection. At 1 year, if there is PHLF, it reduces to 70. At 3 years, it is 45, and 5 years, more or less same. So probably after 3 years, the overall survival is affected. Similarly, the recurrence-free survival is also worse if patient develops PHLF after liver resection. So all the strategies are focused that the patient should not be at unusual risk of developing a post-hepatectomy liver failure. This another, it will be too extensive, AFP, PIVKA2 response to downstaging and mixed tumors is the another important factors. But for liver resection, a single value of AFP per se doesn't remain a contraindication for surgery, but a persistently high AFP or PIVKA2 after curative resection is a bad prognostic factor, and response to downstaging is another key. This is a new area key. Upfront the patient was not resectable, underwent various modalities, and then if he shows a good response, whether that candidate should be subjected for liver resection to achieve better survival. And mixed hepatocolangio is associated with worse survival compared to HCC alone. And to add to the confusion, I tried to make this key. Their guidelines are very difficult to understand, but this paper have summarized about the Japanese, Chinese, Hong Kong, APASAL, EASL, and ASLD. And if we look at this charts, then a single tumor, even more than 5%, most of the East are going for the liver resection. Then EASL is most East and West, single tumor even larger than more than 5% in the absence of vascular invasion. This much I can tell about because I won't go into the ablation, TACE or systematic therapy for this. So ILBS experience 132 liver resection performed over since 2010. Median age was 58. 47% were cirrhotic. CTPA were 88%. B 12%. And most of the patient had no CSPH, but 13% patient had CSPH. Most of them were unifocal. Then there was macrovascular invasion. There was one patient had hepatic vein tumor thrombus. One patient had a VP4 tumor thrombus. 3 patients have right or left portal vein invasion. Sectoral invasion was observed in 7 and V1 in 1. This is the AFP level. Even we have taken a 4,13,000 patient. Tumor size average was 8.4. Range was 2.2 to 20. Size if less than 5 L, 26, more than 5 is. Yeah. Most of it's a mixed, but about 60% are major dissection. 96 R0 resection, microvascular invasion present was 53%, and post-operative liver failure only 7 patients developed, 4 developed grade B and 3 developed grade C. So coming to the summary, liver resection for
What
HCC.
was the age, mean age and gender of ILBS patients?
Sir, 58 mean age.
58 and gender?
Gender, sir, I think they will be.
How many were above 70 or how many were non-cirrhotic?
Sir, 58, 22 to 78. Cirrhotics were almost half.
Outcome in cirrhotic versus non-cirrhotic?
So that I have not compared.
But what was the denominator also is important. What was the denominator? How many patients seen and how were these 132 selected?
Ma'am, that's difficult to take out the denominator because
At least
these are not admitted on surgical side. So that's an interesting what I was coming to, that we can have an audit of patients who whether they were
how
candidates.
many had portal vein thrombosis?
17.
Outcome, survival 1 year and 5 years?
Sir, I have not yet.
So फिर फायदा क्या हुआ यार?
Downstaging and all that has to be
Only
shown.
2 patients.
So commonly done outside, downstaging, very commonly done. What happened to the guy with a 400,000 AFP?
Pivka to Achha.
No, AFP was 400,000. 4 lakhs. Why did he get operated? I'm surprised.
Coming to the summary, liver resection for HCC remains the curative option. The indications are expanding. Clear benefit of surgery when resection is feasible. Careful patient selection in child B cirrhosis and in the presence of clinically significant portal hypertension, and multidisciplinary approach in every case, as the evidence has suggests that it translates into better patient survival and outcomes. So this is the team effort for HCC. Is a diagram ki all of us, radiologist, hepatologist, intervention radiologist, hepatobiliary surgery, pathologist, oncologist are part of the HCC care team. And happy Doctor's Day to all of you. Thank you.
What is your algorithm after reading, reviewing all this? What should we improve in our algorithm of HCC? You must have made some algorithm. How should we change what we are doing from what we should do?
Sir, as what I can show the change is that the study on the multinodular disease or BCLC stage B, that we can evaluate more strictly whether a resection can be offered versus TACE, and what the patient, because probably in our scenario, the patient's decision, which is not reported anywhere, whether he wants to opt for surgery or other therapies, needs to be addressed, because most of the times the Indian patients probably will opt for another alternative even if surgery is offered. That we have not addressed. Ma'am, it's more of child B cirrhosis because the literature is in favor of B7. B8, B9, people are surgeons or hepatologists still are skeptical about offering liver resection. Then again, it's the whether we are going to offer a minor liver resection or a major liver resection. That, and another is because there is a heterogeneity about the clinically significant portal hypertension. Many times we come across that the patient just have like grade 1 esophageal varices or grade 2. Then the platelets are somewhere around 80,000. There is some streak of ascitic fluid, and then we don't know whether we actually call. And again, the HVPG becomes an invasive procedure. Then if it is a large tumor in the right lobe, then HVPG measurements might be fallacious. This is the area clinically significant portal hypertension, child-based cirrhosis, unilateral multifocal disease, then presence of up to VP3 we should go for surgery. That is VP4 also, we should make attempts to downstage and again give a chance for liver resection. These areas needs to be addressed, and probably this is high time because we have a huge data of hepatocyl HCC patients to have a retrospective propensity match scoring analysis, or so we can develop further guidelines of our own.
Okay.
No biomarkers cut off for resection. If there is no extrahepatic disease, no metastatic disease, and the tumor is resectable, we will resect.
But it is not that high biomarkers, they have a circulating tumor cells. They will develop more recurrence after surgery.
But till the data is not there, even 63,000, even last month I operated a patient with PUCA of 4 lakhs, and that is supposed to be a young patient, minor liver resection, just alone PUCA 2, then it becomes difficult to offer.
Can you think in the other way around? Suppose you give some local regional therapy, see the biological behavior, then go for the resection so that you can reduce the risk of minimization. Or there should be any plan of post-surgery like neoadjuvant, it is a adjuvant therapy like to give of immunotherapy or TKIs or no?
It's very
I
important.
personally feel
there is a Kyoto paper, 8 centimeter or larger tumors in non-cirrhotic HCC behave like a cirrhotic HCC, and they have poor outcomes. But I think we have run out of our time. Thank you, Shridhar.
Thank you.
Is there a second presentation? Okay,